And it tells me the recording has started, so welcome to the beginning of Chapter 8, the Appendicular Skeleton, the second of the two Bone ID chapters. Those chapters describing these parts of the skeleton we can see here in normal bone color. The elements of the pectoral girdle, in this case the right, with the clavicle being this joint, being the only bony joint that holds this entire shoulder and shoulder blade and arm, hand, and wrist in position. Same thing over here, the only bony joint. Notice it's the top of the manubrium that it rests on. So we're going to see clavicle and scapula. We're going to see the humerus, the radius, and the ulna. Only 5 bones to get from the manubrium down to the base of the wrist. Down here we can see, and by the way, this is a confusion. People think about the head, neck, and trunk as being the axial skeleton. So if I point to a bone right here, they look and they say, well, this is part of the trunk of the body. It's high up in the chest. In fact, here it's very close to the midline. So it's got to be part of the axial skeleton. No, no, no. The clavicle and the scapula begin the pectoral girdle. And we'll talk about it in more detail as we finish this survey type review. Down here at the base of the vertebral column, remember the axial skeleton is the skull, the vertebral column, and the thoracic cage. Down here, the sacrum, definitely part of the axial skeleton, but attached to each side are the hip bones or coxal bones that form this brim, a bowl-like structure that's going to have a big role in supporting the weight of the tissue above it and of joining to the sacrum and forming what's called the pelvic girdle. Now, not a lot of bones at maturity. This coxal bone develops from 3 growth centers, the ilium, the ischium or tailbone, and the pubis or pubic bone, grow together by bony growth. So at maturity, this is actually one solid bone, right and left, connecting to the humerus, the femur, the biggest bone, the longest bone in the body. And here at the other end of the femur, we're going to see an additional bone, the patella, that's inserted at the break of the knee. This is a really tough joint to build because think of all the body weight that's above the kneecap. And yet somehow this has to have bipedal motion. We have to have very, very strong knees. So we protect the front of it with the patella left and right. And below that, a main large bone, the medial bone being the tibia, and the lateral bone being the fibula. So once again, 1, 2, 3, 4, 5 bones from the sacrum connection down to the top of the tarsals. Now here we're going to see for the first time that foot structure. And look at this. We know right and left. We know this is pedal. We know the raise with the great toe being number 1, 2, 3, 4, and 5. And going from the tarsals to the metatarsals, 1, 2, 3, 4, and 5. And then the 14 phalanx bones. With the same kind of division, 2 phalanx bones on the great toe, proximal and distal, and 3 on toes 2 through 5, proximal, intermediate, and distal. So that's all the bones in the body, and the great parts of the appendages are really those long, strong bones, and a lot of tissue depends on them. Let's go back up to the pectoral girdle and look at the right clavicle. The thing to appreciate here, as you're thinking about the shoulder girdle, the pectoral girdle, is how much this clavicle provides for the attachment with this joint. The claviculo-manubrial joint is the only bony connection. We really see the cone shape of the rib cage. It's not a cylinder, it's a cone. You come up here to the number 1 rib, and you'll notice this in the models in lab. The number 1 rib is tiny compared to the other ribs that are lower down in the rib cage. The clavicle spaces basically provides this spacing that places the scapula out laterally to the rib cage. This region right here is a lot of soft tissue in the shoulder. There's a lot of space. And in fact, one shortcoming of all of our models of the skeleton are that in order to hold it together, we often take the scapula and we just bolt it to 2 of these ribs. And that's not the way the scapula looks in real life. There are muscles crossing over between the scapula and the ribs going to the humerus. This is very much a floating bone. Doesn't have any bony connection except this one to the clavicle and this one. In the back, it is supported completely by a very strong rim of soft tissue. There are muscles coming down from the cervical region, over from the spine. There are muscles that then from the scapula cross over to the humerus. There are ligaments that connect and secure the strength of this shoulder joint by crossing from the scapula to the clavicle. We'll look at those at a later time. So the position of the clavicle within the pectoral girdle, and emphasizing there's a lot of space and soft tissue here. When you think about the body and the way we carry it and the way it works, when we talk about blood supply coming from the heart, it's going to come out kind of under this clavicle and cross over this axillary region. You got to keep those blood vessels out of this moving joint. Got to do the same thing with the nerves. So there's going to be bundles of fibers, blood vessels and nerves crossing over in this underarmor axial region. Here at the manubrium, we have the jugular notch because the jugular vein runs right down behind it. And then this manubrial clavicle joint. Here is the number 1 rib connecting just below it to the manubrium. This is the immovable rib. The clavicle sort of has this double recurved appearance. This end rests on the manubrium, the sternal end, and it moves not just laterally. From the sternum straight out would be about like this. It basically moves curved laterally to the right and posteriorly to form the acromial end. The acromion is the point of the shoulder, and the reason for that body region name. And this is where this end is going to join with the acromion, a bone marking on the scapula. I also want to point out something. Notice how the shaft of this bone is relatively smooth and uniform in appearance, whereas at the end, you have these rims that are bumpy, that appear to be raised and are deeply pitted. The pits extend on the acromial end all the way up to sort of this junction. Now, those pits are going to be places where ligaments and tendons are connected. The orientation of this bone does not show you the facet where it's joining to the acromion of the scapula, or the facet where it's joining to the manubrium. That's more on the inferior surface, and this is the superior view. But you can kind of take a clue from the appearance of the bone. This tells you there's a lot of ligament and tendon action in these end regions as you're tightly, sort of like shoelaces, sending that collagen across from bone to bone to hold them close together, and then allowing the muscle ends through the tendons to attach so that they can actually produce some kind of movement around the joint. The scapula, there's so many different bones where I say it's the very definition of an irregular bone. The vertebra was one, the scapula is another. This is the anterior view. So if the skeleton is oriented as you see here, and we pull it out, so we're removing the rib cage from blocking the view, this is what the anterior side, the rib side of the scapula looks like. It's basically a big triangle, and when you feel it, you'll notice that there's a sort of a bead, sort of a reinforcing pipe around the perimeter of this triangle, because the main forces are left, right, up, and down. We're pulling against it, but sort of along the plane of the skin of the back there. There's very little force at this point moving anterior to posterior. So actually, when you look at a real scapula, the bone here is very thin. It's thin enough that on the dried bone, you could pick up a scapula and take your finger and just poke straight through it. And it kind of shows something about the body. The stresses and strains on these bones have crafted them through natural selection into the shape that meets the need. There's no need to reinforce the bone front to back. You need to reinforce it side to side and top to bottom. And so that's where you find the heavy bony reinforcement. A triangle is a rigid figure, and there's going to be muscles attached to the spine, coming down from the high shoulder and from the neck region above. There's going to be muscles bridging across this axillary region to the humerus, which is hanging in this position. Sticking up above and forming the shoulder, from the anterior side we see the acromion. This is where the clavicle will arch in from the right side. So the clavicle is going to be up above in this position. This bump is called the coracoid process. When you look at the scapula, it's kind of down here underneath the level of the acromion. And this is a tremendous place. The scapula is expanded here for many opportunities for muscle attachment across the shoulder. So one of the muscles that attaches here is the short head of the biceps brachii, the muscle that, when stabilized against the scapula, will allow you to flex your elbow. So the bone markings shown here are kind of typical of bone markings that are on the worksheet. We just call the borders based on their position. The lateral border is this one. The medial border is the one that runs almost parallel to the vertebral column, and the superior border. This is a point that's called an angle. The acromion, the coracoid process. This is the lateral angle, and this curve right here is the edge of the glenoid cavity. This is where the humerus will fit, as you see below. We also see a kind of a depression right here, a little shallow, like a puddle forming. This is called the subscapular fossa, because it's the anterior surface. It's, if you look at it from the back, it's beneath the scapula. Now, I want to say, repeat again, I asked you to learn that table on bone markings. And you can see what its use is here. So we are using terms like process, angle, superior and inferior, lateral and medial, to indicate these positions. And if you've internalized those, the meaning of those names, then these make perfect sense and are easier to remember. The humerus is one of those long, sturdy bones with a long shaft, relatively smooth, but because of the connection across the shoulder and the connection across the elbow, and those being very mobile and well-muscled joints, there's a lot of expansion, bumping around those articular facets, up above and down below. And you can see the division I spoke of. That round globular head of the humerus is sort of just like a half globe, very smooth. But you can see a rim, and then around that, the bumps that we've named, the greater tubercle and the lesser tubercle, and the divot between them. This is sort of like a pulley called the intertubercular groove. Now, the biceps brachii is going to be positioned with one of its heads right up, running a tendon right through here. The anatomical neck and the surgical neck of the humerus are different. Anatomically, this is where the head joins the bone. But if you're performing surgery for repair, this is what you consider the neck. The long shaft has a ridge called the deltoid tuberosity because this is where the deltoid muscle will attach. The deltoid muscle is what runs over the top of the shoulder and produces abduction at the shoulder. Over here at the bottom, we see a number of other markings, but the first thing we notice is this region I'm circling with the pointer. You see that its surface appears smoother, more uniform. These are articular surfaces. This is a globe of the capitulum, and this is sort of a pulley-shaped groove called the trochlea. These are the 2 points where the radius and the ulna attach separately to form the elbow joint. But up around these articular surfaces, we see great big bumps and deeply pitted features, indicating the attachment points for tendons and ligaments. So the radial fossa is a depression near the radius side. The lateral epicondyle means the outside bump above the condyle, and the medial side is simply on the medial surface. The elbow joint is really interesting because of the 2 bones connecting to one. The head of the radius is a shallow bowl-like head that attaches to this globe called the capitulum. Now that allows the radial head to rotate this way. So when we use our muscles correctly and turn our hand over, what we're actually doing is rotating the radius on that capitulum. You'll notice it doesn't change position. In the anatomical position, the radius runs on parallel to the ulna below. The lateral bone is the radius. But when I turn my hand over, there's actually an X formed as the radius at the wrist is now on the medial side and the ulna is on the lateral side. That's because of the rotation of the head of the radius on the capitulum. Next to it, we have a very different story. The trochlea is like a pulley, and the coronoid process of the ulna forms a wedge that fits into it, but it's so deeply curved from front to back, it's like a sickle. And so when I flex my elbow and extend it, that's the ulna basically moving in this trochlear groove. Because it's pitched like this, it can't move from side to side, it can only move front to back. And so that's what defines the elbow. I can flex my elbow and extend it, but we know it stops there. It does not hyperextend, and that's because of the structure of these bones. There's actually something like a doorstop built into the ulnar joint on the other side that fits into a hole. When it hits the bottom of that hole, then extension stops. This is that posterior view showing you that bump on the back of the joint, the olecranon, and it's going to fit into an olecranon fossa on the humerus and stop. So there's not just ulna on humerus and radius on humerus. Because the lower arm really functions as one bone at maturity, we have to tie the radial head and the ulnar head together. And there's a joint called the proximal radial ulnar joint. Proximal means closer to the shoulder, doesn't it? And radial ulnar meaning connecting the radius and the ulna here. We're going to have a similar joint here. The ulnar notch will allow for a joining joint of the radius and the ulna at the distal end. And in order to reinforce these two separate bones and keep them stable relative to each other, we see a vast number of ligament connections that go from bone to bone and basically act to lock these bones together. Kind of shows you something about evolution. This part of the lower limb, the genetic plan says make it out of two bones. And the lower part of the limb has two bones, whether you're the wing of a bat or the leg of a lion, or the arm of a chimpanzee or of a human. We make it out of two bones. It can be the, for example, the flipper of a sea lion for swimming. Two bones in this position between what is the elbow and the wrist. But the very, very different structural needs of swimming, flying, running, or climbing has produced these changes like the interosseous membrane, locking these two bones together. All right, here we are at the hand and wrist, and we're back to that formula. Look at all the bones. Here is the anterior, and so now we say anterior. Well, what does that mean? Well, the anatomical position, palms face forward, so this is the palm side of the hand. We can readily see the rays 1, 2, 3, 4, 5 with the Roman numerals indicating the metacarpals and the proximal bones to the metacarpals being the phalanx bones. Notice 3, 3, 3, 3, 2. So the proximal phalanx and the distal phalanx. I think I said intermediate phalanx. Middle phalanx is all labeled on this figure. Either one will work. So that accounts for the 19 bones of the metas and the phalanx. That leaves the bones of the wrist. Now, these bones are all short bones, and they're a complex and very flexible region. If you isolated the joint between any two bones, so for example, this joint right here, between the capitate bone and the adjacent hamate on the palm side, this joint, that joint doesn't actually allow very much movement. However, when you notice the capitate is in the center, forming a joint with the 3 metacarpal, the 2 metacarpal, the trapezoid, the scaphoid, the lunate, and the hamate. There are so many joints around there that it turns this junction into a very flexible but powerful part of the body. That means this: we can flex our wrists very rapidly with great dexterity to do light tasks or dexterous tasks. But if we have to push the car, we apply a lot of force, and these short bones are wedges and boxes that jam together into a kind of solid configuration. So we can actually put a lot of pressure on the back of that wrist without damaging it. Now, I mentioned these 8 bones, and the mnemonic that I use, so long, tiny pinky, here comes the thumb, starts here at the base of the thumb and at the joint with the radius. So I'm starting right here, and I'm going to go from the lateral side to the medial side, across here. So long, tiny pinky stands for scaphoid, lunate, triquetrum, and pisiform. Now, those three that are first are in a line, but the pisiform actually sits up on top of the triquetrum. So that bump, that knob you feel here at the base of the number 5 ray, that's the pisiform bone sitting on the triquetrum below it. So in the picture it goes scaphoid, lunate, triquetrum actually out of sight. Notice on the posterior view you can see it, and you can't see the pisiform. And the pisiform shown on the anterior side. Now we drop to the, here comes the thumb. Hamate is this bone right here. Capitate, trapezoid, and trapezium. Here comes the thumb, takes you right back to the base of the thumb. So long, tiny pinky, here comes the thumb. That mnemonic was introduced to me by a student in one of my A&P courses. Michael had taken my botany course first and my biology course and decided to take A&P, and he came up with so long, tiny pinky, here comes the thumb. I don't know if he got it from somewhere else or made it up himself, but I've always liked it. So when you add these 19 to 8, that's 27 bones right there. Together, that's 54 bones when you add right manual. Now, looking at it from the other side, it's pretty clear what the metacarpals and phalanges will do. But in order to interpret from the backside, you're going to start again at the base of the thumb, the number 1 ray, and the junction with the radius. So it would start right about here. So, so long, tiny pinky is out of sight. Here comes the thumb. Now, when you get that mnemonic down and you can practice it and look at the figure and it works, then stop, clear your mind, and just look at the wrist again. What are the things that jump out at you? What jumped out at me is the central roll of this capitate. It's a big bone right at the base of the number 3 metacarpal. It forms clearly the center of the wrist from the anterior side, and although it's a little less prominent from the posterior side, it still is very central. So I noticed that first. Second thing I noticed was the position of this pisiform. So with those two landmarks really clear, and I got to the point I could not mistake them, I could use the mnemonic and always work my way back to the sequence and name all the bones. Good luck to you with those names. So that completes, we've worked our way all the way down to the end of the pectoral girdle. We're ready to look at this pelvic girdle. Now, the pectoral girdle, we've arisen on our back legs full time. That's different from other great apes. When you look at a chimp, you're looking at an animal that can walk on its hind legs, but does so without great grace or ease. And in fact, the chimp is a facultative quadruped. When it's on the ground and either chasing something it wants to catch or running from something it wants to get away with, it takes its knuckles on its front and it puts them down on the ground and it gallops. So it's a facultative quadruped. We are not. When we're in a hurry, we never put our hands down and try to gallop. We always stay up on two legs. That means our skeleton is going to change very dramatically. Our pectoral girdle is going to get lighter. It's going to get weaker, but it's going to become much more dexterous. And that's going to be a trade-off that's built into the bone structure and built into the muscles that move them. The more flexibility you allow, the weaker the joint. So the strongest joint is an immovable joint that's joined by bony growth, like here in the seam of the femoral bone. Immovable joints like sutures and fibrous connections. They're immovable. Those joints are very strong. As we allow slight movement with cartilage pads, like the intervertebral disc, those junctions are a little flexible. They allow a little bit of movement, but they give up a little bit of strength. And by the time you get to an elbow or a knee, vastly movable joints. They're very, very flexible, but relatively weak. But if you take another approach and say, well, let's compare the pectoral girdle with the pelvic girdle, we have two extremely different roles for those two appendicular elements. The pectoral girdle, the arms, the shoulders, arms, hands, and wrists are for grasping, carrying, manipulating. They are never for running and supporting that great weight. So in general, they're much more flexible, much more dexterous. It's the reason that if we're going to learn to play the flute or the piano, we use our hands rather than our feet. Because at the other end, we see the principal job of attaching to our legs, our ambulatory regions, and supporting all the weight of the upper body. So the pelvic girdle is formed from three different growth centers, independent bones, that will fuse with bony growth as they reach their adult size. So looking at this coxal bone or right hip bone, we're clearly seeing the much larger socket called the acetabulum, where the head of the femur will fit. We also see a wide array of odd angles and projections and points and edges for the attachment of the massive muscles of the thigh, of the buttocks, and of the lower back, which are controlling, orienting, and then eventually propelling this pelvis and the movements of the body. The color on the model above shows you the approximate growth of the three bony elements that form the coxal bone. The ilium is this large flag and the upper part, and it grows halfway down, forming about a third of the acetabulum. In the back, the ischium. The ischium is the tailbone. As you sit down and you feel that solid contact between your body and the chair, that's the ischium providing that solid bump. And then up from the ischium and across the front of the pelvic girdle is the pubis bone, shown here in pink. Notice that if we were going to fashion this, we'd take a single piece and we'd either mold the whole thing, or we would use a 3D printer to cut it out of one piece, or we would, if it was wood, we would use carving tools or other sculpting tools like Dremels in order to cut it out of one piece. But we grow this body one cell at a time. We start out as a single cell. And what the cell can do is grow these elements independently and connect them, fuse them into a single continuous coxal bone, pelvic bone, that forms the, in this case, right half of the pelvic girdle, as you see here. Now, the markings on the pelvis are very large in number because if you think about it, we're looking at the lateral view here of the right hip with the socket here called the acetabulum. And we have to secure the femur in here. We have to run muscles from the back all the way down from this lateral crest, all the way back down the spine to the sacral connection. You'll notice these loops and bumps, the notches, the holes, like this obturator foramen allows muscles from the inside of the ilium to run down in this direction and go through that hole in attaching to the femur below. So a very complex, irregular bone, this right hip bone. This shows the anterior view. This is that right hip bone or coxal bone. This would be the ilium portion here. And this would be the junction with the pubis bone over to here. And in the back, the tailbone is the ischium, forming mainly the lower loop. This pubis forms the upper part of the rim, as you can see here from its connection with the ilium, over to this midline, and approaches the pubis on the other side, the left coxal bone. This is one of the more interesting joints in the body. It is one that allows, they say, slight movement. It is very strong fibrocartilage, which in men throughout their life is just as close to immovable as you can get without being there. And in women, for the majority of their life, is immovable. But it has an interesting role during gestation and childbirth. Because the main stress point in human reproduction is getting the baby's head out of the birth canal. That baby's head has to move through an opening, the birth opening shown here, that is surrounded by bony parts that do not stretch. And this kind of shows you that this was not thought out and designed at a time. Birth in most mammals is actually very easy, does not threaten the life of wild mammals, because if childbirth kills you, your genes don't go anywhere. But in domestic animals, where we have help, where we are free of predation, and in human beings, where we've moved most of our selection from the natural world to the social or cultural factors, this is a real problem in childbirth. So one of the things that happens, the hormones associated with delivery soften this somehow, so the pressure of the child's head moving down onto the pelvic rim and through it, pushes on it, actually pushes these apart a little bit. It stretches to allow for a little bit more circumference and a broader opening. You can kind of relate the structures you see here with the model above. Here is the L5 vertebra and the final intervertebral disc to the top of the sacrum. Here are those openings that show you clearly 1, 2, 3, 4, 5 segments to the sacrum. Here is the very broad and irregular sacroiliac joint, where the sacrum joins the ilium of the coxal bone. This is called a slightly movable joint, but it actually has to be very strong, because the strength of our posture is not in the individual bones, but it is in this bowl-shaped structure. Think of the force that's being applied to this joint, left and right, as we walk or as we run or jump. And think of the flexing of the powerful muscles that surround this pelvis above and below. So this has to be a very, very strong joint. The color coding shows you the central blue part, the part of the axial skeleton, the sacrum and coccyx, and it's binding to the ilium above, the pubis, which is really posterior more, and basically forms the tailbone as it loops forward. And then this is our best view of the pubis bone so far, coming over, forming that pubic symphysis connection, and basically arching down and attaching to the ischium. The ilium, the ischium, and the pubis weld together by bony union to form the coxal bone. Below that, the femur, the largest bone in the body, longest, strongest, heaviest, and forming the major portion we call the thigh, a large part of our lower appendicular skeleton. This is a wonderful bone to point out the clear bone markings. You'll notice this globe, because this is supporting so much more weight all the time. The acetabulum is not an open kind of saucer-shaped cavity like on the glenoid cavity on the shoulder. It's more of a cereal bowl, a deep bowl. that basically arches over the top so that that joint can rest right here on the curve of the globe, the main contact point being right here and straight down. The globe is mounted on a very strong neck, but one that decreases in diameter. That's why we call it a neck. And this allows for something when you're tying this head into the acetabulum. You could actually take a collagen fiber around this head and then wrap it around this narrower neck. And it basically catches up against the back of this edge, providing greater support for locking this articular surface, the femoral head, into place. The center part of this head has a divot. You can barely see the edge of it here, called the Fovea Capitis, and it shows another necessary adaptation when you really have to keep that joint in socket. There is a ligament that actually grows into the head and attaches by embedding to collagen throughout the bone and crosses over the joint through the middle and actually attaches to the bone at the back of the acetabulum. So when you look at the joint like this, there's a fiber running, a rope in the center of it. As you walk, it basically is twisting and untwisting, but it's keeping the head from pulling out of the joint. Now, we've used the word process many times, and here we see the reason for the different levels. Here's the greater trochanter and the lesser trochanter, a great big bump, a little bitty bump. It also forms this crest or rim, you can see, that runs all around the base of the neck. This is the intertrochantic line, meaning it runs between the trochanters. The shaft is long and relatively smooth in appearance, although there are lines. See these lines? These are for the attachment of leg muscles that are going to cross the hip above or the knee below. Down here, if you look at this posterior surface, look at that smooth articular surface and the split between them, the fossa between the moving articular surfaces. Around the outside, you see, as I said, deep pits, medial epicondyles. On the medial side, there's something above the condyle where ligaments and tendons attach. That's where the rough appearance is. So look for those bone features as a clue. Here we're looking at a very unusual view. If you take the femur and lie it down with its anterior side up, and then look at the knee from below. This is the inferior view. It shows you the lateral and medial condyles of the right femur and the notch that is present, a medial facet on the femur and a lateral facet of medial and lateral facets that basically fit exactly with the patella. The patella, when your leg is straight, sits up in this notch. It's not really spanning the opening, but when you bend your knee to a right angle or beyond, this patella comes down in the opening that is spanned by all the ligaments and tendons of your operating knee and protects it with a bony covering. Down below that knee, here we're looking at the posterior view, and we have turned it around. So basically we're looking at the posterior view of the tibia and the fibula. There's that interosseous membrane again. It's more important that they operate like one bone that's strong from top to bottom, and so we bind them together. We do notice that if you look at this skeletal figure, the main bone of the leg is the tibia. The knee joint itself is formed between the femur, patella, and tibia. Notice that the fibula only attaches to the side of the tibia, but it does allow for certain interesting joint movement. When we look at the lower leg, we notice that the tibia is medial and the fibula is lateral. So looking over here at the posterior view, this is the right, because this is the medial side, and this is the left. Now here we have a very interesting feature. The fibula just up at the knee joint just hooks onto the tibia. It doesn't get involved with knee action, flexing and extending the knee. But down here, at the base of the tibia, we're going to try to attach the ankle and foot. And that's going to be to a bone called the calcaneus. The talus. The calcaneus is below it. That means we're going to have a very tight bracket that holds the talus from moving laterally or medially. And we do that by extending the fibula down. There is a notch, and it fits into that notch, and strong collagen fibers lock it in. But it kind of shows you something. When you have solid bone, over here on the tibia, here is this little styloid process sticking down. You can barely see it, but it may come down 1/4 of an inch, and that's enough to keep the talus from moving medially. But over here, this is a joint, not solid bone that supports it, and it's much weaker. So you have to have this big surface area, this big extent of bone that wraps down around the lateral edge of the talus and secures it from moving laterally. That's kind of the difference between a solid bony support and a two-bone and joint-derived support of a joint. Here we are back to those ankles and feet. For some reason, the ankles compared to the wrists were just much easier. We'll show you this, but here is the trochlea, the upper surface of the talus that the tibia is resting on, and below that, the very large and irregular calcaneus, the heel bone. And from the side, and even in the box, those two bones are distinct in their irregular shapes. That left 5 tarsal bones here. And the other thing that makes them easy to remember is that these 3, at the base of the 1, 2, and 3 metatarsal, are all called cuneiform bones, and they're named according to a formula. The great toe is on the medial side. This is the medial cuneiform, the intermediate cuneiform, and the lateral cuneiform. So my experience when I looked at them was to say, whoa, these 5 bones are easy. Now, I have to admit, I do have some problems deciding which side the navicular bone and the cuboid bone are on, but the navicular is behind the cuneiforms on the medial side. The cuboid is adjoined between the calcaneus and bridges over to the base of the 4 and 5 metatarsals. So talus, calcaneus, medial, intermediate, and lateral cuneiform, navicular and cuboid, 7 different tarsal bones. I do not have a mnemonic for that, although many of my students report different ways of remembering them. Now the rest, and by the rest I mean 19 bones, respond to the formula we used on the hand. These are called metatarsals, since it's a foot. You can determine, since the great toe is medially, and if you look at your own feet, you can see that this is a right foot. So if I had a bone on here, I would begin by just writing down right pedal. Get it out of the way. The rays identify the position of the metatarsals. So if I said right number 3 metatarsal, that would be a complete identification of this bone. However, if you get out here into the phalanx bones, you're going to have proximal, middle, and distal bones on 2 through 5, and only proximal and distal on the number 1 digit, called the hallux. So if I wanted to identify this bone, I would recognize immediately it's the middle bone of 3 phalanges, and it's on the number 4 ray. So if I said right pedal, number 4, middle phalanx, that would be a complete identification of that bone. And we're not going to do it in this course, but I just want to call to your attention that Chapter 9, we're going to learn that these joints all have different types, so that if you actually learn to pick up a small bone, for instance, this one, the right pedal proximal number 2 phalanx, the number 2 proximal phalanx. If you look at this bone, these joints between the metas and the phalanxes are condyle joints, and the joints of the toes and fingers are hinges. So the proximal bone here has a condyle and a hinge. The middle one has a hinge and a hinge, and the distal has a hinge and a free end. The metacarpal has a condyle on this end and a planar or gliding joint on this end. So the joints and their identification you can even take the disassembled bones and identify them in terms of name and position. When we look at the foot from the side, we see a very complex structure because unlike the hand, this structure is supporting our weight and through strong muscular movement, moving our body anytime we're not sitting or lying down. So here we see the upper talus resting on the calcaneus. Now we're looking from the medial side, so this is the right foot. This is the number 1 ray with the the distal and proximal phalanx, the metatarsal number 1, the medial cuneiform, and the navicular lining up. We'll notice that the orientation of these joints produce arches. And arches are sort of like springs. Tie these together with ligaments, and they stand in a curve. Put weight on them, and they flatten out, stretching those ligaments. When you stretch those ligaments, it's not just one part of the foot that's supporting the weight. Every single joint of these many joints is being stretched and participating. We have an orientation of these foot bones so that the longitudinal arch is front to back. The calcaneus, you can see, is definitely at an upward angle and lifts the navicular and cuboid free of the ground. The metatarsals are sloping back down to this ball of the foot and the presence of the ability of the phalanges to press down. So the longitudinal arch runs from back to front. If you looked at it in another way, there would be an arch that's transverse from the number 1 to the number 5 ray. So the construction of this in arched form provides a kind of a suspension or a springing action every time we step down on one of our feet. Now, we will, for every organ system, emphasize the way the organ system grows and the way it matures, and at the end discuss age-related changes. And the skeleton is one of the more interesting systems because it obviously changes in size and shape so much. And here are some of the features that need to be pointed out, because we're not born with a mature skeleton, we grow one. I know that a number of anatomists, because they look for the completion of actual bone growth in the whole body, will say you don't really stop growing until you're 28 or 29. The major elongation, the major increase in height and dimension is usually over before that. But let's take a look at a couple of features of growth and of aging. Bony matrix. the deposit of those hydroxyapatite crystals into osteons, into the tuberculi of spongy bone, is occurring throughout life. The events of aging, we notice a reduction in the mineralization of the bone. It shows in x-rays. The bone become less and less opaque. And at some point it crosses over to a debilitation, a weakening of the bone that we call osteoporosis. This actually begins at somewhere between 30 and 45 in middle life and goes on slowly. The values of decline vary between men and women. Basically, by the time we reach 65 or 70, we have a significant weakening of the bone. Bone markings, likewise, reduce in size and roughness. And I want to point this out. When we become weightlifters, let's say we become really serious about it, we're lifting serious free weights. We look and we see the muscle mass increasing as our muscles grow bigger and become leaner. But what we don't see is that we're actually building strength and pulling harder on those joints, so that in a healthy young person, the bone markings like trochanters, tubercles, become larger and more mineralized, bigger, bumpier. With age, we see a consequent reduction in that size and roughness. As we become less flexible, as we get sore in our joints, as we move less, there's a reduction with increasing age and with loss of muscle mass. Now, growth, the fontanelles are the soft portions that are between the growing plates in the skull. And closure of those fontanelles to really bony edges that are actually adding slowly, completed by age 2. The frontal suture is much more variable. The right and left growth centers will fuse together by bony growth along here. At the same time, they're forming sutures with every other border. So this bony fusion can occur and be completed anytime between age 2 or 8. And there are skulls that you will see where that bony fusion is incomplete. There's a kind of a line left there. The occipital bone is one that grows and fuses to the ossification centers, right and left, ages 1 to 4. That styloid process on the temporal bone that sticks down, a very noticeable but very thin spike of bone, is going to grow for a period of time because it connects to the hyoid and affects voice. It actually has something to do with the musculature and the change of voice at puberty. 12 to 16 years, it is finally fused in a bony, in complete bony growth. This is a great example. In a skull, it's very difficult to keep a skull with the styloid intact, because if people handle it, you press on it from the side and it's dry, it snaps right off. But in a living body, you don't get that kind of movement. You've attached a muscle, but it's going to pull along its length, and it's plenty strong in that dimension. The hyoid bone is also associated with the larynx and the voice box. And look at this. It's not completely built until after the age of 25. This is when our voice stabilizes for life. Teeth, we're well aware we have 2 sets. Baby teeth, which grow into the jaw as the jaw grows, and then in a recognized sequence of replacement, the second set of teeth replaces them as the jaw grows. We'll talk about this further in the digestive system in A&P2. The mandible right here. Aging, as we see with the maxilla above, we experience loss of teeth as the bone mass gets reduced, as vasculature is reduced. The angle of the mandibular notch changes, and this gets more and more problematic as we age beyond 60 years. The vertebra, back to the axial skeleton, the major curves, of course, develop before the age of 10. By this time, the weight on the spine is kind of imbalanced. And although you continue to grow after 10, you add bone and bone mass as you add weight, and consequently the curves are pretty well established. The intervertebral discs, though, after 60 years old, they reduce in size. They become less springy, less elastic, and they contribute less to height. So the shrinkage in height is not generally due to the shrinkage in the height of the individual vertebra. It's due to the compression of these intervertebral discs. Since there are so many of them, if you lose even in 1/16 of an inch, you can, end up losing more than an inch of height across the whole spine. Long bones, we see the epiphyseal cartilages fusing at different ages. Different bones grow for different periods of time, but in general, you can look at epiphyseal cartilage and its development and estimate the age of the bone of the person that the bone came from. Pectoral and pelvic girdles, those epiphyses have a narrow range of ages, and they also can contribute to good estimate of age from skeletal remains. So that's our quick lecture review of the appendicular skeleton, and it contributes